So apnea of prematurity is typically seen after 24 to 72 hours. There is cessation of breathing for over 20 seconds, or it may be for a shorter duration but associated with bradycardia or desaturation. And it's mainly related to immaturity of the respiratory center. There is also a higher threshold for CO2 response. Suppose a baby is holding the breath and the CO2 starts rising, that triggers your respiratory effort. But in this case, the threshold is higher, so the baby holds for a longer time. And in that time, the FRC may drop, the lung may close down because the lung is not normal, and you may become desaturated. The oxygen may drop. There is also a paradoxical response to hypoxia in the premature baby. Suppose we stop breathing and we become hypoxic, we tend to breathe fast again. But in a premature baby, if there is hypoxia for any reason, they stop breathing for a brief time. So this causes apnea as well. And we have chest wall reflexes like Herring-Brewer, the stretched reflexes in the airway. Pharyngeal hypotonia plays a role as well in obstructive apnea, and reflex laryngospasm, because these babies have higher risk of gastroesophageal reflux, and the reflexing contents can hit the airway. There is a reflex laryngospasm, which again leads to the cycle I told you of lung going below closing volume, FRC dropping, hypoxia. And hypoxia itself may cause more hypotonia, so everything may aggravate. We have three types: central apnea, obstructive apnea, and mixed apnea. Central apnea and obstructive apnea are common. So most of the apneas tend to be mixed because one leads to the other. If there is central apnea with hypoxia, which causes hypotonia, the airway obstruction follows. If it's an obstructive apnea and it leads to hypoxia, this hypoxic central response takes over and it becomes a central component as well. The baby stops breathing. Initially, they continue breathing if it's obstructive apnea, but the airflow is not adequate. Apnea of prematurity is a diagnosis of exclusion. If it doesn't follow the typical pattern, you need to look for secondary causes like worsening lung disease, sepsis, electrolyte imbalance, and so on. So hypocalcemia can cause, even if temperature instability, if the baby is overheated, they are at higher risk of apnea. If they're hypothermic as well, they may go apneic. Polycythemia is a known factor as well. So we use caffeine to prevent and manage apnea, and if there is persistent apnea, you use non-invasive ventilation to try and maintain the FRC. However, if it's more advanced, you may need to intubate and ventilate the baby. However, intubation ventilation is more likely to be needed if there is secondary apnea due to worsening lung disease, sepsis, and so on. So we have prematurity as a main factor. The central response is different. Inhibitory reflexes, CNS pathology, meningitis or IVH can lead to apnea. Infection in many ways, including the cytokine response, stiff lungs, and so on, can lead to apnea. Impaired oxygenation due to whatever reason through the prematurity and the hypoxia-related response. And metabolic disorders, hypocalcemia especially, can lead to apnea as well. And hypoglycemia can present as apnea. So this is the three different types. In obstructive apnea, you have a normal breathing pattern. Suddenly the airflow stops, though the thoracic movement is maintained because there is some obstruction. The oxygen saturation drops here. In central apnea, the baby stops breathing, there is no airflow and the oxygen drops. And in mixed apnea, you may have either of the two patterns, either it starts as central and becomes mixed, or it may be starting as an obstructive and due to the hypoxia, it becomes central.